I hate to interrupt all of this wonderful chatter that I'm hearing in the room, but we must indeed. Good evening, I'm Gabriella Rosa. I am an alumna of the school, MPH Clinical Effectiveness 2022. Woo! That was from Jane, because she gave me my degree, so I was very excited. And I'm currently a student doing the DRPH program, the Doctor of Public Health program. I'm in my second year. I feel like I've been at the school for a very long time. I've done multiple programs since 2018, so I'm really ready to graduate for real this time. And I promised myself that I will not go for a PhD. You know, I think that that's a really smart thing to do. So as I get to introduce these fabulous people, on the very first panel for Alumni Weekend, this year we have the right to health, equity and justice for all. And the whole theme, you know, this whole plenary session is titled Towards Racial Justice and Equity in Health, a Call to Action. And some familiar faces, we have featured panelists this evening, Zinzi Bailey, Justin Feldman, and Jasmine Graves. And our moderator, none other than David Williams. And Dr. Williams is the department chair of the Department of Social and Behavioral Sciences at Harvard Chan School of Public Health. And he will be moderating today's discussion. Thank you very much for being here, and I look forward to seeing you all tomorrow at all of the events that we have coming up. Thank you.
All. It's great to be with you this evening. And we have a wonderful panel to talk about this topic. Now, back in the mid-1960s, Stokely Carmichael, Kwame Ture, and an activist, and Charles Hamilton wrote a book called Black Power. And in that book, they coined the term institutional racism. And they used the term institutional racism to refer to all aspects of racism that were operating in society, not at the individual level. And they argued that that's where the real action was the extent to which racism was embedded in policies and practices and the actual organization of society. Today, the term, that was the historic term used for probably 25 years, and today, terms systemic racism and structural racism are used in the ways in which they originally used the term institutional racism. And we want to take a deep dive this evening in thinking about, is racism really real? I receive every other day, it seems like, an email from Christopher Rufo. Most of you have never heard of him, but he's the most influential person on the right in the United States. I think of him as DeSantis's brain. In laying out, really, he's the driver of anti-critical race theory, the driver of anti-DEI policies. I've received from him a model to be used in every state of how to make DEI illegal. I don't know why I'm on his list, but anyway, and he has argued that racism is a thing of the past. He's listed in one of his things, the 7 civil rights legislation of the 60s that made racism illegal in America, and racism no longer exists. So first to the panel, you have all done work on racism. How, in your work, have you measured racism, and how have you looked at the relationship between racism and health? Because for many Americans, racism is a thing of the past, doesn't even exist, illegal since the 1960s. How could it matter for health?
So, hi. That's a huge question for us, so I'll take the first stab.
Just each of you take a stab, but you have all done work in this space, so
yes.
Tell us a little bit about what you have done and how you measure racism and what have you found in terms of its impact on health.
So I think I've come at the relationship or investigating the relationship between racism and health from multiple angles. Some of my work has focused in a little bit more on an interpersonal racism and how that affects, for example, elements of mental health. However, a lot of my work, especially as I've moved forward, is touching more on that institutional racism of the 60s and what I've call it structural racism. There's multiple different theorists around there, systemic racism, but really thinking about the things beyond the individual or even the interpersonal. So thinking about the policies and practices that we have in place that systematically disadvantage some over others, and at the same time, it impacts our decision making around all of our systems. So thinking about how we have decided to have the healthcare systems that we have, how we've chosen to fund them. So personally in my research I've worked on some operationalization of that term of structural racism, of thinking about multiple dimensions of structural racism, so operating in multiple domains. So thinking about healthcare, thinking about criminal legal system, thinking about education, thinking about a range of different domains where it is operating on a systemic level. And then thinking about that in relationship to health. So there's the explicit attempts at measuring maybe the downstream factors of structural racism, almost trying to get at a kind of latent idea of what structural racism is by looking at kind of measures comparing, for example, Black and white individuals with regard to high school completion and other things like that, graduation rates. So ratio measures and that sort of thing. But then also I've taken a step towards particular intersections. So thinking about things like housing and health and how that intersects and reflects mutually reinforcing systems. So within the COVID pandemic, thinking about housing security and how that interacted with evictions and how people were able to manage their health subsequently. So I think from that standpoint, thinking about it both from a conceptual standpoint and getting at those dimensions, but also thinking about a deep dive into the intersections. And I will leave it there and allow others to answer.
Each of you, the same question.
Yes.
Your work on racism, how do you measure it, and what are you finding about it? How does it matter for health?
Yes, I'm just taking a moment because I get to sit next to Dr. Bailey, and I'm a fan, you know? If you're not a fan of your friends, what are you doing? So my work has kind of taken two different approaches to addressing structural racism. Less so much on the measurement side, because in my career I've mostly worked as a qualitative researcher. So really getting into the depth and of the richness of people's experiences and putting words and story and narrative to the harms that people have experienced as it relates to racism. And I've largely done that through documenting the harms of carceral systems. So I spent the first few years of my career in New York City government working as a qualitative researcher out on Rikers Island and some of the other city's jails. And my kind of initial project, or what brought me into the work, was the leadership of a human rights physician by the name of Homer Venters, who was noticing that in our medical records, there were all of these really serious injuries that would routinely come in. And I'm talking about like skull fractures, orbital fractures, jaw fractures, and the cause in our medical record would say slip and fall. And so he knew just intuitively, like, something's wrong here. This person didn't get a skull fracture from falling in the shower, right? So he was looking for someone who had qualitative research experience and a certain kind of, dare I say, abolitionist lens towards the carceral system to kind of come in and start to really sit with people and begin documenting and understanding what was happening to them. So that really shaped most of my kind of research work when I was in government, was going in and interviewing people who, felt comfortable enough in that unsafe environment, quite frankly. We try to say, we create safe spaces, but there's no such thing as a safe space in a jail. So in spaces where folks felt most comfortable, just sitting with them and beginning to document what really happened to them, and then finding, unsurprisingly, that the vast majority of the causes of those injuries were correctional officer brutality. So I did a number of interviews, I want to say, between April 2012 and August of 2012, I think I interviewed upwards of like 82 people across the city's jail system and documenting, again, what was really happening to them. And we were really lucky enough to be able to turn over the findings from those interviews to the U.S. Department of Justice, which launched their CRIPA investigation into the brutality that was happening on Rikers Island. So much of my research has been this kind of qualitative component qualitative component to a lot of our quantitative work in that particular bureau at the health department. So that then led to a line of investigation and inquiry to the harms of solitary confinement. So we did a study assessing who had the highest rates of self-harm, or the populations that had the highest rates of self-harm in our city's jail system. And as you all, I'm sure, can imagine, it was people who were confined in solitary confinement, also young people living with a serious mental illness. And so it then became my job to go in and interview people and ask if they felt comfortable to share a little bit more about their experience in what we would call the box, to help, again, really humanize the experiences of people who are incarcerated in our city's jail system. Which was really kind of transformative, that a government agency, which is usually tasked with protecting a political administration at all costs, would be courageous and radical enough to begin sharing and documenting the real human experiences to challenge these narratives around the criminalization of mostly Black people. So that's like my research work around addressing racism. In practice, and I feel like there's research and practice is kind of like the same thing, because I hate being that person who offers that distinction, but for lack of a better word, my non-research related work in my career was mostly kind of like doing this kind of internal thinking and advocacy work at the health department. I'm looking at Natalia because we got to work together along with Zinzi in our time there, and really pushing through the leadership of our commissioner, Dr. Mary Bassett at the time, pushing people to really think beyond the kind of individual and interpersonal forms of racism, and think about what does structural racism look like in our city? How is it shaping population health in our city? How does it shape neighborhood health? And how can we leverage our $1.3 or $4 billion budget at the time to really address what was happening to people, or what people are experiencing. So I kind of got to shift into practice through that experience, and then continued on until I left the city. And when I left the city, I was working at City Hall at the time. So I really got to push other city agencies, not just to think more critically about how they're creating and reiterating and reinforcing structural racism in our city, but to actually be doing something about it. So I had an opportunity to really be in a position to begin shaping what budgets look like, and advocating less for, programs that were more police focused, and advocating more for financing and investing in programs that were more health focused and health promoting. So yeah, that's kind of a little 50,000 foot view of some of my work.
Thanks. And now I'm even more grateful to be here today, because I had no idea that you did that injury study, and it overlaps a lot with what I'm about to describe and a lot of my work. So I started studying police violence as a doctoral student for my dissertation. And even before that, this was 2014 and early period of the Black Lives Matter movement, the police murder of Mike Brown. Just starting with the question, how many people do police kill in the United States, and why does mortality data not properly capture that? And I would consider the absence of an adequate government-sponsored system for monitoring state violence, which is heavily racialized, a pretty strong piece of evidence in terms, if one wanted to prove the existence of structural racism, that would be it. We count so many things in this country. Every fatal car accident, in theory, should be counted through various systems. Every dollar of GDP gets counted, but we can't manage to count people killed by police or in police custody. More recently, my work has, I've followed it through multiple sorts of rabbit holes and been inspired by protest movements that have taken place over the last decade or so. I have been doing some historical work. We're interdisciplinary in social behavioral sciences, trying to understand this set of categories, diagnostic categories that get applied to people who die in police custody that range from improbable to impossible. These are conditions like excited delirium, you may have heard of, lethal catatonia, et cetera. And what I have found is a few different things. One, there's this category called excited delirium, which finally, after many, many years, starting in 2020, professional associations have started to contest the existence of. Essentially, it's attributed only to people who die in police custody as an alternative explanation to why they died, as an alternative to say they died of positional restraint, asphyxia, chokeholds, et cetera. But there's no clear etiology of it. And when journalists have covered this before, and it hasn't really received much critical attention from other sources, they kind of see this as this weird idiosyncratic thing that cops probably made up one day. It turns out that it comes from a forensic pathologist. CDC sent an investigator to work with him over a period of multiple years and helped build a body of research around this stuff. Additionally, I found there are many deaths in police custody where the pathologists point to sickle cell traits, which is not sickle cell disease, which is highly unlikely to cause death. It's known to happen in cases of elite athletes overexerting themselves and new military recruits. And I found in 1990, high-level CDC researchers produced a paper on chokehold and restraint deaths where they speculate that sickle cell trait could explain the racial inequality in those deaths. So we see a pattern of disproportionate deaths in police custody observed among black people being understood epidemiologically not as the result of racism, disproportionate targeting of police, or racist and more violent treatment of black people, but instead speculation about so-called innate biological differences that could lead either sickle cell trait or excited delirium to be more common among black people and thus explain that inequality. And this is something there's a long history within our own field and within our own government of trying to legitimize this that we've yet to reckon with, I think.
Thanks so much. Just to throw in for the audience, I want to give you one other example, some from my own work. In 2001, I wrote a paper with Chiquita Collins where we argued that residential racial segregation was a fundamental cause of racial inequities in health. And just to give you examples of data, I'll draw on two studies from Harvard economists. One study using national data for the United States, using fancy econometric models I cannot even fully describe. But the study finds that if we could statistically eliminate residential segregation in the United States, we would completely erase black-white differences in income, in education, and in unemployment, and reduce black-white differences in single motherhood by 2/3. All of these large, striking differences are linked to opportunity at the neighborhood level. And the second study, Rash Chetty, using census data over multiple decades, asked an intergenerational question. And the question was, let's look at black and white children that begin life with households at the same level of household income. So you're controlling for household income. How are the children doing in the next generation? And what did Rash Chetty find? And remember, not a sample, all census data over multiple decades. What did he find? He found that black boys have lower earnings than white boys in 99% of census tracts in America. Why? Because they're lazy? No. Because they're not working hard enough? No. Because they live in neighborhoods that differ in access to opportunity. Black boys do as well as white boys if they're in neighborhoods with good resources, but there are few such neighborhoods where black children are living in the United States. So just an example of a mechanism of structural racism. There was a historian at Duke University, John Sell, wrote a book about the origins of segregation in the US South and South Africa, and he argued that residential segregation in America was one of the single most successful domestic policies of the 20th century. It's beneath the radar screen. Politicians are not talking about it, but it drives inequities in powerful ways. Let's turn back to the panel. As you think of your own work in this space, what do you think are some of the common misconceptions in the field of public health for research on racism and health and trying to understand its health consequences? What are some common misconceptions? What is it in the field of public health that many in the field don't understand or think of it in the wrong way?
I'm going to offer the first spot.
Thank you.
Oh,
Someone
someone else.
else.
Oh, you're offering us an opportunity
I
to go
just
first.
spoke, so.
Okay, so I guess that's me. Wow, okay. Interesting, that's a great question. Common misconceptions. Well, I don't know if it's so much a misconception as much as it is like, I think people have a natural inclination to focus on the interpersonal and get really frustrated by the structural, by the institutional. Something I think, I keep looking at my friends, former colleagues here, that we heard a lot in city government was like, yeah, you know, housing, really important, but too expensive, you know? Or those structural problems like, yeah, ooh, they shape population health, but we just don't have enough money to really address them, you know? And the audacity in a city with a $95 billion budget to say something like that. So I think less perhaps a misconception, but a missed opportunity, right, is for us to really think more critically about how we can leverage the resources of our field. And again, I'm coming from, you know, a career that's mostly in government, so I'm thinking always about how do we leverage the people's money, which is tax money, which funds everything, in various jurisdictions, whether you're in a city or a county, to really address the vestiges, and not even vestiges, but the actual like practice of structural racism as reflected in mutually overlapping systems, right? Whether that be our criminal legal system, right? So like, what does it mean to invest in decarceration? Whoa, it's very possible. We saw it during COVID, and I hope we come back to that conversation in a bit, right? What does it mean to literally, for public health agencies, for healthcare systems, like I'm thinking about Dr. Mitch Katz's work when he was in LA, to literally invest the dollars of that system in building housing for people who are houseless, right? So I think that these less perhaps are misconceptions, but are really gross missed opportunities in our field by still kind of working through a limited scope of what racism is, how to measure it, and what we can do about it. So that's kind of like my
misconceptions, missed opportunities, whichever way you want to think of it.
Yes.
What have you seen?
You're okay.
I mean, if I just piggyback on that, where I feel like a lot of times when I get into a discussion with somebody else who's in the field, then it becomes what will NIH fund, right? And then it narrows the scope way down so that you're not even getting at structural racism anymore or systemic racism. You're talking about an interpersonal intervention, right? So a lot of the times thinking too narrowly in terms of thinking about broad scale change. This is not something that we're gonna get overnight, like results in 5 years and like it's done, it's over, right? It's not gonna be over suddenly. So I think for a lot of folks, I think there is a missed opportunity around scope. That doesn't mean that one individual or one agency is gonna take on everything, but I think that there are many opportunities, missed opportunities for collaboration and intentional thought around larger structural change. And that, I think, requires not just the public health field and professionals, but also partnership with social movement, partnerships with community organizers, partnerships with broad scale change that us as public health professionals are not gonna be able to do on our own, right? It's gonna require partnership. It might not say the Bailey intervention, right? It's gonna be something that's gonna be a partnership that leads to broader scale change.
Justin?
There's probably a lot of misconceptions,
Yes.
I think
like that.
There's a ton.
Like that structural racism doesn't exist, for example.
example.
That's probably pretty widespread. But to kind of build off of what each of you said, I think it's either a misconception or just something that I don't see us thinking through enough, which is we have finally come to this moment, 2020 comes along, and you have big foundations, and you have some government agencies like NIH, CDC, stated local health departments saying, structural racism is a problem. Racism is a public health emergency. We need, within public health, to do something about it. What I think is not entering the discussion, and is perhaps a misconception, is the degree to which there is opposition to us doing anything about it. And I don't just mean from Ron DeSantis and white supremacists or explicit white supremacists or that sort of thing. I mean from sort of one, on an economic level, and two, within our own organizations. Think about housing, such a huge pathway through which racial inequality is produced and reproduced in the US. If you think about how cities work, they need to raise money, which they are largely doing through bonds, which are sold to financial industry as speculation on future property taxes. So it's not just that every city council and mayor in the US is corrupt and a sellout to the real estate industry, is that they are structurally tied to them, even if they didn't want to be. So I think these are enormously large tasks, and you mentioned social movements, Zinzi, and I think about the civil rights movement and the Mississippi Black Freedom Party that really put the Democratic Party in a hard place and created a crisis in order to push them into supporting civil rights, because they were not going to do that alone. So I think we need to be thinking about how can we, as a profession and in working with social movements, create crises and create opposition that's needed to overcome this entrenched opposition to structural racism, like fighting racial injustice, rather.
Can you just quickly add?
Yes, absolutely.
I don't know if it's a misconception, but what I also see missing in our conversation in the field is a grounding in racial capitalism. So I think that we talk about structural racism, and there's like a growing, a much larger understanding than from when I first entered the field, and that's really encouraging to see. Like, people recognize, like, oh, this is systemic, as we've been talking about. But the point at which people understand the ways that it's rooted in an economy still, I think, is a huge gap. And I think about systems of enslavement, for example. And when we talk about systems of enslavement, I think now we recognize that, like, oh, slavery built the economy of this country. It is the economic foundation. But then for some reason, moving forward, we've lost that, or not that we've lost it, that same understanding doesn't get applied to what's happening now. And I think in the context of carceral systems, you know, because of the work of Angela Davis and many other incredible activists over the last few decades, we understand, like, oh, the prison system is an industry, and there's a whole prison industrial complex. But insofar as we apply that to the other facets or systems that are interconnected with the criminal legal system, and like the industries that are pushing them, shaping them, and tied to them, I think that there's just a huge gap. And I think if we don't take the moment to ask ourselves, what's shaping these systems? Because they're dynamic, they're ever changing. And they're not just dynamic and ever changing on their own just because, like, oh, there are a few people who like really don't like black people. Like, no, it's like, this is very much tied to profit. And until we, I think, get to a place where we really root ourselves in that understanding of what racial capitalism is and its relationship with structural racism, I think we're gonna always be a little bit behind the ball in our analysis and understanding.
Thank you so much. I want to give you one of my gems of misconception.
Oh.
Happened maybe 2 decades ago, but a reviewer said in response to a paper I'd submitted, the term racism does not belong in a scientific paper. And the reviewer went on to say, racism is an ideological concept that cannot be measured. So that's my gem of a misconception that's out there. Hopefully not as much as it was 20 years ago. But you're all working in this space. You all look into the future. What gives you hope that we as a society can be successful in our efforts to confront racism? What gives you hope?
I guess I will start. So I think this is, I struggle a lot with the hope piece, because when we get into it and how deep this is, it can seem like this very, very long-term endeavor. But what brings me hope is actually looking historically and thinking that we have been working towards racial equity for a long time. And there has been some progress. And there are people who are surviving, right, and thriving, or, building community despite all of these things, right? So for me, what brings me hope is actually the points of contact that I have of organizers who are in Florida still organizing, changing names of things and going covert and doing all of these things, but still fighting for their communities and fighting for, a different world than the one that we currently live in. So for me, the hope is in our continued commitment to racial equity for those of us who are there, and for where I'm seeing a lot of people in our field who are refusing to back down on language, refusing to back down on the progress that we have made. And so I hope we can continue that and continue to push forward.
Yeah, two things come to mind that give me hope. One is also rooted historically, but it's seeing the legacies of people like Ida B. Wells live on in our work. So I think about your work, Justin, with Dr. Krieger, and advocating that police killings are public health data that need to be counted. And like seeing that direct tie to Ida B. Wells' work documenting the number of lynchings that were occurring across the U.S. South. And documenting it, and then also offering an analysis alongside it, right? So it's not just to say, 1,000 people were lynched within this particular period, but let's get into each of these cases. Let's talk about what led to their lynching so that you understand the human beings who are being subjugated or subjected to and subjugated by this extrajudicial practice. And I very much see that legacy reflected in your work. So things like that very much give me hope that, like, wow, over a period of centuries, which is also then connected to the abolitionist work in the 19th century, right? We've been able to carry this fight on. I mean, some could see it as like a little demoralizing, like, damn, it's been a couple centuries. Still arguing for this. But on the other hand, I also see there's something really beautiful in seeing those legacies continue to live on and be uplifted. The other thing that gives me hope is really outside of the field, if I'm just very honest, it's people. And I think about when I was working on our city's COVID response in the winter and spring of 2020, and I think we'll come back to this in a moment, so I'm not going to get too much into the failures and things that we learned. But what I will say is that when we dropped the ball on meeting people's needs so that they could stay at home, it was the people of New York City who stepped up. Ooh, sorry, I get a little emotional talking about it. Who really stepped up, right, and created all sorts of mutual aid networks to support one another, right? When we could not, and I'm using the royal we, wrap our minds around universal basic income for people who could not work from home and then were also losing their jobs. People were crowdsourcing funding to support people in gig and service economies, right? When we could not quickly wrap our minds around decarcerating our city's jail system that had, at the time, 40 times, the infection rate was 40 times the national infection rate. People came together and organized a mass bailout. So that is what really gives me hope. Which also comes back to like the conversation we're having around movement spaces, but it's really the people that we talk about serving, that we look at in big data sets, who give me the most hope.
Yeah, I'd say kind of building on that. We really are at a time of, if not really vibrant social movements, then at least really large mobilizations of people. And we saw tens of millions of people take to the streets in 2020 to protest racism and state violence in a way I'd never seen in my lifetime, at least. And not only that, but I see a knitting together of different movements and concerns. If you think about the Stop Cop City movement in Atlanta that's explicitly tying in concerns about not just the expansion of policing, but also connecting it to climate justice and connecting it to public health through environmental justice. And I just have to say, like, I get emails and Twitter DMs and end up talking with a lot of people who are coming into public health programs really trying to reconcile what drew them into the program, which was a sort of burning desire for racial justice and social justice more broadly, and what it means to be a professional and an academic and in a public health program in the 21st century, and all of its like hyper focus on the sort of technical and statistical aspects of the field. And those are really hard things to grapple with, but I think the fact that so many of them are doing that, and we have all these students coming in with that mindset, that gives me hope.
I like what you all have said about hope, and hope is important in this work. And when I get asked that question, I always tell the reporter, it's my students. And it's true. Zinzi,
Literally.
right? It's one of my students. But really, it does. It makes a difference as you see this new generation that's impatient with the realities that we confront. Time is ticking really quickly, so I want us to focus on interventions. What can be done in this space? And we can think, you can choose whether you want to talk about interventions that would improve health or interventions that would reduce the gaps in healthcare, because there are racial ethnic differences and racism within healthcare delivery, and there are racism in the larger society that affects health itself, the determinants of health. Could we talk a little bit about what you think of as some of the most important interventions that would make a difference in dismantling the systems of racism to ensure better health?
Yeah, I can go first this time. You're looking at me. I'm pretty focused on policing these days, so I'll talk about that. There are some positive things going on in terms of interventions. So I think it's pretty self-evident at this point, almost, at least for most people, that policing is racist, or at least there are racial inequalities in who police use force, including lethal force against, with Black and Indigenous people getting the highest burden. What we're seeing more recently is taking police out of schools and bringing in different kinds of programs modeled around restorative justice. Sometimes those programs come about as a result of teachers' unions partnering with community groups of parents. We see shifts towards what's being called alternative crisis response. So people in mental health crisis, rather than have an armed agent of the state come to their door, have someone who is trained to deal compassionately with people who are experiencing those states. We have, if not in practice, but at least in the movement and in thinking, arguments around needing to put more funding into programs that are either in the domain of public health or support social determinants of health in ways that would decrease racial inequities, rather than give endless amounts of money to the carceral state. So that's happened in some places. There's been backlashes in some places, of course, but it's at least on the radar.
Thanks. Who wants to be next?
We're not going to rock, paper, scissors. The question was around interventions?
Yes.
Right.
Yes, and interventions. What would you recommend? Not necessarily what you have done, but what do you think are the needed interventions to address racism?
Yes, there's so
in terms of how it affects health?
Oh my
well,
God.
Talk about the 2 or 3 most important ones.
Yeah, 2 or 3 most important. Okay, so what comes up for me when I'm in the similar conversations to this one, is recognizing that the way forward, one is, I think, bringing ourselves back to realize that what people need are basic human rights. And what racism, structural racism in particular, does is rob people of their basic human rights, right? We're talking about basic food, shelter, a right to education, a right to medication, healthcare, very basic, right? So I think that the way forward and the interventions are very clear. If you just invest in people's basic human rights, then I think that'll take us a long way, right? And I think there are, intermediary steps that I've seen that are encouraging, like in my time in government, seeing us shift resources away from policing and the carceral state to more health-centered and focused kind of programs. And I think that's really encouraging. What I will also say, though, is that those systems and those responses are also deeply racist. So I think until there's a couple things that need to happen. There needs to be a fundamental shift to recognizing human beings and their dignity and who they are and respecting and loving them, and their experience and honoring their experience and expertise. And I think that it's also literally looking at our budgets, which are moral documents, right? What we fund is who and what we value, right? And beginning to maybe think less about spending $1 billion on a, multifaceted mental health program for the city of New York, which was really important. It was really important. But thinking about how many people could you have housed with that money is what I think about, right? How many people could you have housed? How many people could have been fed? How many jobs could have been created with that money instead of investing it in something that became, a potential political platform for another person, right? So I think it's really quite basic. I don't have a complicated answer. I think that the answer is investing in people's human rights and fundamentally changing the ways that our systems operate and what we value.
How do we do that? When you say investment, it sounds nice. I love to do it, but what needs to happen that would really invest in human rights for individuals?
From the vantage point that I'm coming from, right, sitting in meetings with the first deputy mayor of New York City, right, and arguing around what needs to get funded, there are agencies and folks who put forward proposals to invest some of their new needs budgets in creating more housing, right? Okay. But there comes down to a decision, as an example, right, of what does investing in a structural intervention look like, right? But then it comes down to a decision. Someone says, well, actually NYPD, needs robo-dogs, okay? And that's gonna cost $15 million. So, actually, rather than funding an expansion of the supportive housing program, we're gonna fund these robo-dogs. So those are the decisions and the moments that I'm talking about. They're very clear.
Very helpful.
Very clear conversations and meetings that happen not at press conferences, but behind closed doors, where people are making decisions about what gets funded and who they value, right? So in those same neighborhoods where you could have created more housing, you decided we needed robo-dogs to patrol housing developments, rather than fix the lights in the housing developments or fix the elevator, or maybe just create new developments for those people from that neighborhood. So to me, that's a very clear choice and decision around how to make investments in people's basic human rights.
Thank you. Very helpful. Zinzi.
Yes.
Interventions. What can we do?
So interventions, and I'm going to agree with the ones that have already been stated, but I think more, examples of that, I think they're the same old that makes them not that exciting. So thinking about, more targeted universalism and thinking about having access to healthcare and that being a thing, right? Everybody having equal access to healthcare. Thinking about tenants' rights. Thinking about housing and how housing is funded and how developers are incentivized to, produce certain types of housing. I know in my neighborhood or the neighborhoods in my city, there's tons of housing, but it's luxury high-rises, right? So there's a fundamental disconnect, but that happens at the point of decision-making, and it's decision-making for our leaders. So I think one of the key intervention points is not something that NIH can fund, but it's actually finding leaders that can make those decisions, being able to root them out and actually support them, vote them in, or, if it's, other ways of getting into these positions, moving towards that. I think our healthcare system needs a complete overhaul. Like the criminal legal system is rooted in, a very settler colonial past. We need to rethink that. specific interventions, I mean, we can start with insurance, but like that's like the very tip of the iceberg in terms of what we would need to do in order to make sure that people are coming into a system that actually meets their needs, meets it in an equitable fashion, and that, you know, they want to be there. So.
Yeah,
Thank you. Yes, go ahead.
Because when you said, you know, the NIH, of course, isn't gonna, there are certain things they can fund, but I don't know, I think about like, what does a world look like where the NIH, in addition to funding research, is also funding structural interventions? You know, like these things I think are possible with enough people power to push for it, right? Like I'm sure 20 years ago, well, no, because of course the Freedom House ambulatory service has already modeled for everybody in the 1960s what it looks like for people from a neighborhood to provide emergency medical care. So I'm not gonna say like maybe 20 years wasn't a thing, but it wasn't certainly popular to think about health-only responses to what's considered a crime, right? That wasn't always a thing, but with people pushing, something changed, right? I think, you know, for a long time, right, we saw substance use as a crime, as something like that needed to be handled by the carceral state. And, you know, the shift is also racist. But nonetheless, we saw, or we're in a moment where we're seeing people recognize that, like, oh, wait a minute, crime, like race, is a social construction. We can decide, oh, substance use is not a crime. It's something that people deserve support for. So in that way, I think that, you know, some of these structures that have existed and only funded, you know, certain types of causal inference studies can be pushed and changed and shifted to fund and finance and invest in things that I think actually, not that causal inference doesn't matter, because it matters and it's an important method. It's so important to make a lot of the cases that we make. But nonetheless, I think that like direct investment in what we know will shift population health rather than another study to explain how it's harmful. It's possible.
Probably my last question, I'll see what time we have. But as you look at this audience tonight, I want you to speak directly to the audience about how they can contribute to addressing racial justice. We've talked about police and prisons and housing, but there are public health professionals here, there are physicians here, there are other professionals. What can the average professional do to promote racial justice in our society in ways that would enhance the health of populations?
I'm going to start and say that, I mean, I think one first step is recognizing that racism exists. And it's not just like a random thing that happens, you know, down the street somewhere or in a prison. It's happening every single day in the rooms that you're in. You might be participating in it, right? So like all of us, right? So what are the decisions that are being made or discussions that are being had that you're a part of, that you can insert and ask questions? Be critical of how funds are allocated, for example. Why assumptions made about the direction or the risk factors of a particular patient, and why they might need to be, forced to stay in a hospital because they're Haitian and Black and right? Like there are questions that you can be asking on a daily basis, multiple times a day, in every conversation that you're having around why we are making the decisions that we make. And I think one key component of structural racism is that it normalizes this kind of tiered system of expecting poor outcomes from certain people. It's a natural way of being. It becomes something that's, differences are reified and we think, oh, it's natural for this to be happening. But there are key decisions that are made every single day, multiple times a day. And in places of power where you have resources behind you, that one interpersonal decision becomes an institutional and structural decision that has lasting power. So I think for each and every one of you, I think it's being able to think about how the natural assumptions or decisions that you make every day may have racial implications and may be rooted in racism.
Thanks, Zinzi.
All right.
Yes.
Along those lines, I think what everyone can do, and I'm sure is already doing, is exercising courage and political will. So I had the privilege of starting my work in New York City. It's a weird, maybe privilege isn't the word I want to use, but when I first started, I worked under, no shade to Bloomberg, but maybe shade, lots of shade actually to Bloomberg. I started under the Bloomberg administration, and I remember, and I was working on the island at that time, and I remember like all of us having to do our work very quietly so that things wouldn't get to City Hall and then have our work completely tamped down, right? And not even to the level of City Hall, even the commissioner of our agency at the time was like, no, we don't want to upset, we don't want to ruffle any feathers, you know? So it really, our work had to happen very quietly, and we had to get very creative about how the work was disseminated. And then I remember the tide changing. I remember Dr. Bassett coming in. And I remember it being like a radical shift, like almost day and night, and what it meant to have someone in leadership who exercised that courage, and I think political will in a lot of ways, who, you know, we went from having a commissioner who was like, y'all, just make sure they get their medication, okay? Nobody's asking you to document brutality. Nobody asked you for that. To someone who was like, no, we need to, you know, platform what's happening to people, and then we need to do something about it. We need to actually end solitary confinement, and if we can't end it, then at least 15 days. I mean, gosh, limit it. People are there for years. What's happening in a jail? So I saw the power of that courage and political will, and I think, and it's certainly what inspired me when I got to my position at City Hall, to be that person in the room. Like, you know, I know that this is unpopular, but I'm gonna say it. This is the decisions that we're making in this room, one, are racist and are gonna have deeply harmful implications for, in the project I'm thinking about in particular, for Black and Latino people living with a mental illness. So I'm sure, I know, right, this is a Harvard alumni event. Everybody in this room, I'm sure, has the power, or at least proximity to power, to exercise a level of courage and political will that shifts some of those decisions and can make a difference.
I think those of us who go through very many years of education often aren't taught how to actually make change, especially in collective ways. So that would be a place to start. And like the 30-second version of that I could give you here is take an inventory of the different communities you're part of and have power in. That could be a workplace, a union, a professional association, a school, a local government or neighborhood. Those are places where you can make change and that have their own power. Then you find other people with similar interests, in this case, who care about confronting racial injustice that's either happening internally or through the policies of your organization, or both. And then you make a plan. That's sort of one way of thinking about it. Another is thinking, as a professional, you have specific skills that can be used as ammunition in the fight against oppression. And there's plenty of examples of this. One example, you likely live in a place that has what's called a COSH group, or a Coalition for Occupational Safety and Health. Often those are explicitly focused on racial justice in terms of who is harmed by toxic exposures or other health hazards in the workplace. And these were created in the 1970s by professionals and public health professionals and physicians thinking, what can we do to advance racial and social justice right now? And that was one of the many answers they came up with at that time. So you can involve yourself in a COSH group or other sort of group where there's room for bridges with public health professionals, or you can think about approaching a community organization and talking through how you can lend technical expertise in ways that will help them become stronger.
We're all citizens, we're all voters, and some of us may need to run for political office, right?
You!
To make a difference. I'll leave it for my students. We have time for one more. Great. So
I think from the audience.
Oh, a question from the audience. Okay. No, it's not an amazing one, but I do want to leave you. I do want to leave you with this thought. W.E.B. Du Bois, the first black person getting a PhD from Harvard, wrote a book called The Philadelphia Negro in 1899. Has a chapter on Negro health, lays out the disparities that exist in these different wards in Philadelphia. And as he comes near the end of the chapter, he pens these words. He says the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation to the well-being of the race. And Du Bois continues, there are few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. We've been talking about inequities in health that exist. What Du Bois said in 1899 is still true today. National public opinion data shows that most American adults, if you get to 50%, and some of them it's great, but it's typically in the 40%, know that racial inequities even exist. And they're typically asked about racial differences in life expectancy or infant mortality. Most people don't know. So there's inequities on a broad scale, there's human suffering on a colossal scale produced by racism, and many people don't even know it exists. So one of the challenges we have is how do we tell the story of the challenges of all populations that are suffering in ways that connect with individuals, not only raise awareness levels, but build the empathy, and so that we'll generate a political will to do something about it. And that's a challenge I would want to throw out to the audience as I want to give you a chance to ask a quick question or two. Yes?
Yes, I'm Sheldon. And one of the things, some of the largest health systems are non-for-profit. And I think in lieu of taxes, they have to do community benefit. And one of the things I spend a lot of years trying to advocate for the use of community benefit for affordable housing. These are some of the things that we can advocate for because there's a large amount of money in those community benefits.
Okay, affordable housing. One last question we can take. Another one over here. Yes?
Thank you. I'm glad that you mentioned W.E.B. Du Bois as a man with immense foresight and a wide view of healthcare. And we haven't mentioned not only racism, but also capitalism. I have to mention that the economic system certainly has something to do with the discontinuity and competition in healthcare rather than a single national system, which many of us have hoped and worked for so many years. And beginning just a few miles from here, in Roxbury community, there was one scholar on the faculty of the School of Public Health that was encouraging of noting the differences between the health within the neighborhood despite the wonderful tertiary institutions in the city. And so one could see, this was Professor Paul Wise, and many others on the faculty.
Yeah, quick question.
Yeah, okay, the question is this. Do we not have to also mention, question raised, under capitalism, is it possible not only to eliminate racist competition and wasteful spending on healthcare, and therefore improve or lessen the distinction, maintain the equity in health as well as in economic well-being, because we all realize that poverty, whether in Roxbury or Beacon Hill, has something to do with the health of not only children but everyone. And when we speak about racism, don't we also have to mention the economic system?
Thank you for the question. I'm going to turn to the panel. One of the panelists didn't elaborate, but did mention racial capitalism explicitly. Yeah. But any one of you quickly have a response to the question?
Well, I mean, quick, and then I'm going to turn to Zinzi, who recently wrote about racial capitalism. No. Answer is no. Racial capitalism in and of itself requires a mass working poor, requires inequity, which I think, I appreciate you asking to bring that into the room. So yeah, my quick answer is no.
Zinzi, a quick response as well?
I would say, well, in addition to Jasmine's question, it's that these are going to be, they're interlocking systems within this nation. So we can't address one without addressing the other. And so I think it's both ways. We can't say, oh, we're only going to do poverty eradication programs without thinking about racism as well. So.
And I want to add your point about a universal healthcare system. Of course, we need that. But even within the universal healthcare system, we need to think of the larger racism within the society and about the racism within the healthcare system, even though everyone in theory has access. Yeah. And I'll give you a factoid that makes my point eloquently. Halfway through the pandemic, national data for the United States revealed that if we looked at age-adjusted mortality rates from COVID-19, African Americans, Native Hawaiians and other Pacific Islanders, Native Americans and Latinos all had death rates from COVID-19 that was between twice as high to 2.7 times higher than that of whites. In the United Kingdom, where there is a national health service, where everyone in theory has access to healthcare, at the same time the data came out from the UK, blacks in the UK had death rates from COVID-19 that was 4 times that of whites, Bangladeshi, Pakistani 3.5 times higher than that of whites, Indians twice as high as whites. So simply a universal healthcare system that doesn't fundamentally address the inequities that exist within healthcare, and we don't have time to discuss it, doesn't solve the problem. So just complicating it, that we have to get at the underlying racism. I think our time is up. Let me say a big thanks to a wonderful panel.
Thank you for your wonderful insights. I'm sure everybody will agree that it's a wonderful conversation and extremely important conversation to continue. I would love to uplift the question that you asked, which I absolutely adored, which is what gives you hope? And as a takeaway for this evening, as we walk into our reception that's going to precede our dinner and the alumni award of merit dinner that we're going to have. And for those interested, there is the recording of this session that will be available after the weekend is complete. Thank you.